Thank you. We welcome everybody to today's meeting and look forward to the discussion. So everyone should have received a copy of the minutes from our previous meeting. And so are there any questions or comments about the minutes? Hearing none. Do we have a motion to approve?
Move to approve.
All right. Thank you, Dr. Turner. Do we have a second?
Second.
Thank you, Colby. Appreciate that. All in favor? Aye.
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 Any opposed? Hearing none, the minutes are approved. Do you have any housekeeping at all, Brian, that you're aware of?
We do have a few things. I'll start with a couple things, and then I'll let Sapide give an update on the situation with Change Healthcare. So we've got two new board members joining us today, Jordan Kaczynski and Sam Wardell. And I'd like to give each of them a chance to introduce themselves to the board. Jordan, why don't we start with you?
Perfect. So, yeah, hi, Jordan Kaczynski. I'm a pediatrician and a child psychiatrist working for the University of Utah. I mostly work with neurodevelopmental disorders, autism most specifically. And so, yeah, I'm excited to be here because most of my population is Medicaid. So, because I work at the Neurobehavioral Home Program as one of my main clinics. So, yeah.
Well, thank you and welcome to the board. All right.
I'll go next. Hi, everybody. My name is Sam Wardell. Sorry, I'm currently traveling, so internet is not working so great today. I'm a pharmacist and previously worked in retail and managed care at Molina Healthcare. I actually recognize Luis. Nice to see you again, Luis. But I appreciate everyone, this opportunity to be here. I was referred to Noon by one of my MSL colleagues, Neil Catalano. So currently I work at Indivior as medical science liaison. Company focuses on treating patients and manufacturing products for opioid use disorder and other mental health disorders and opioid overdose treatment. So thanks, everybody.
Thank you, Sam, and welcome to the board. And we also have one board member who this is her last meeting, Judith Turner. I'd like to give you an opportunity to say a few words.
Well, I've enjoyed and appreciated being on the board these however many years it's been. I'm pulling up stakes and moving to Seattle next month. So on to some new opportunities.
Well, best wishes as you move on to new things, and thank you for your time on the board and your service to the board. And with that, I'll actually, I've got one other thing before I turn it over to Sapide. We will be, as part of a project to update our website and make sure everything is clean and accurate and up to date, we will be updating the bylaws. And so we'll work on a draft with some updates to the DURB board bylaws, and we can present and vote on those at the May meeting. All right, and Sapide, if you want to give an update on the situation with Change, that would be great.
Good morning, all. Thank you, Brian. The Utah Medicaid pharmacy vendor, as you know, Change Healthcare experienced a network and system outage on February 21st, which impacted our ability to process pharmacy claims for Medicaid members who they were attempting to fill prescription. As of March 12th, which we mentioned last time, pharmacies are once again able to bill Utah Medicaid directly, a claim paid for member prescriptions. Since then, there is still no change in the first phase of the system restoration from March 12th. We are still waiving the PA and also the copay. We are waiting to see if we can just get approval for a couple of spas, and that's where we are. Our patients, they are able to receive their medications, but it's still no further update on where we are and where we are going to go with the next phase in the system restoration. It's work in progress. Thank you.
I think that's all we have for housekeeping.
Great. Well, I'll steal it back from you and say welcome to Sam and Jordan. We're glad they joined and are part of the committee now. Going forward, we appreciate the update on change, and we'll look forward to seeing some updates in the bylaws. So with that, I'll turn it over to the University of Utah to talk about short-acting beta agonists.
All right, thank you. Let me just pull up my slides real quick. All right. So good morning, everyone. The goal of today's presentation is to discuss our retrospective review of short-acting beta-2 agonist, or SABA, utilization among Utah Medicaid fee-for-service patients with asthma, with a focus on frequent SABA use. To provide an overview of reliever and maintenance therapies and to guide our descriptive analysis of SABA utilization, we reviewed recommendations from 2 recent asthma treatment guidelines, including the 2023 guideline from the International Global Initiative for Asthma, abbreviated GINA, and the 2007 and 2020 guidelines from the U.S. National Asthma Education and Prevention Program, abbreviated NAEPP. Asthma is a heterogeneous chronic pulmonary disorder typically caused by airway inflammation and is characterized by airway hyperresponsiveness, reversible airway obstruction, and recurrent symptoms. Approximately 5.5% of children and 9.7% of adults in Utah had asthma as of 2021. Asthma severity is assessed retrospectively based on the intensity of treatment required to control symptoms. Treatment of asthma is guided by steps that roughly correspond to asthma severity, with steps 1 to 2, 3 to 4, and steps 5 to 6 corresponding to mild, moderate, and severe asthma, respectively. Most people have mild to moderate asthma. Regardless of asthma severity, all people with asthma are at risk for an exacerbation, which can be life-threatening and unpredictable. Reliever therapy, such as SABAs, is guideline recommended for all patients with asthma, regardless of asthma severity, to manage breakthrough symptoms or exacerbations. Observational evidence supports that high-frequency SABA use as monotherapy or in combination with anti-inflammatory treatments like inhaled corticosteroids is a predictor of asthma exacerbations or mortality. It's hypothesized that harms from an over-reliance on SABAs might be due to the lack of anti-inflammatory effects and/or the decreased response to treatment that occurs with regular frequent use. Review guidelines recognized frequent SABA use as a symptom of poor asthma control and as a risk factor for exacerbations, as shown in this table. Depending on the guideline and the patient's age, use of a SABA-only reliever more than 1 to 3 times per week, excluding to prevent exercise-induced bronchospasm, or EIB, is one of multiple possible symptoms of poor asthma control. In agreement with observational evidence, the GINA guideline considers using 3 or more SABA 200 actuation canisters per year to be a risk factor for exacerbations. Guidelines also consider the risk of exacerbations associated with frequent SABA use to be dose-dependent. So the risk increases as SABA use increases beyond 3 canisters per year. A 2023 expert guidance statement on SABAs advises that providers monitor patients' SABA usage while also ensuring continued patient access to SABA refills, since this is a rescue therapy. Experts also note that in addition to total SABA usage, increases in the frequency of SABA usage from baseline is an important indicator of an exacerbation. For example, an increase in SABA use by 50 to 100% above baseline. Increased or frequent SABA usage should prompt the provider to review the patient's inhaler technique, provide education, and/or consider changing the patient's maintenance regimen. Generally, guideline preferred options are those with superior efficacy and/or safety evidence with robust high-quality evidence to support use, and preferred therapies are typically considered the treatment of choice at the population level. Alternative options are generally considered to be less effective and/or have lower quality supportive evidence. The alternative options may be selected based on patient intolerance to preferred options, patient preferences, or if a patient is already well controlled on an alternative regimen. Reliever therapy is recommended by guidelines for all patients regardless of age and disease severity. Notably, SABAs, either as albuterol or levalbuterol and administered by inhaler or by nebulizer, are a preferred or alternative reliever option for all patients. This table provides an overview of guideline recommended reliever options by age group and treatment step. The P next to the recommended reliever therapy indicates that it's a preferred therapy, whereas an A indicates it's an alternative option. Note that the reliever is selected based on whether the patient is using a maintenance therapy and which maintenance therapy they're using. Reliever options include SABAs, either as monotherapy or in combination with inhaled corticosteroids or ICS, that is, ICS used as needed whenever the SABA is used, and ICS in combination with the long-acting beta-2 agonist formoterol. SABAs are preferred for young children aged 0 through about 4 or 5 years, depending on the guideline. For children aged 5 or 6 through 11 years, SABA is a preferred reliever, except at steps 3 to 4, where ICS formoterol is preferred by the NAEPP or is an equally preferred option to SABA per GINA. At steps 3 to 4, ICS formoterol is encouraged or recommended as a single inhaler option for both maintenance and reliever therapy, abbreviated MART. To encourage ICS use for mild asthma, GINA also prefers as-needed ICS with SABA at step 1 and considers ICS as an option at step 2 for children ages 6 to 11. For adolescents aged 12 years or older and adults, GINA prefers ICS formoterol reliever therapy that is used as MART in steps 3 to 5. SABA alone or SABA plus ICS are alternatives depending on the step. The NAEPP also prefers ICS formoterol as MART for adolescents and adults at steps 3 to 4 and prefers SABA reliever at step 1, 2, and 5 with ICS SABA as an alternative option at step 2. Notably, since 2019, GINA has preferred that all asthma patients 6 years of age or older use an ICS-containing therapy, either as part of the reliever therapy or maintenance therapy. In contrast, SABA monotherapy is a preferred option from the NAEPP at treatment step 1. Despite guideline recommendations in favor of an ICS-containing reliever regimen in many scenarios, other than the inhaler albuterol budesonide, with brand name Airsupra, such use of ICS products as needed is technically off-label in the US, which possibly impedes access or use of ICS as part of reliever therapy. Asthma maintenance therapies are those treatments used on a continuous and scheduled basis. Typically, maintenance medications target airway inflammation to improve asthma symptoms and reduce the risk of exacerbations. Maintenance therapy is recommended by GINA and the NAEPP for all patients with moderate to severe asthma and is an option for some patients with mild asthma at step 2. Single products that can satisfy a complete guideline-recommended preferred or alternative maintenance regimen contain either ICS or leukotriene receptor antagonists, abbreviated LTRAs, such as montelukast. ICS-containing regimens as ICS only or ICS with other medications to intensify treatment, such as LABAs, are preferred maintenance treatment by GINA and the NAEPP. LTRA monotherapy is an alternative option to ICS-containing therapy at step 2 for all ages and an add-on option to ICS at steps 3 to 5 per GINA. Keep in mind that there are some scenarios in which intermittent ICS therapy is an option, such as for patients with seasonal allergy-induced asthma that lack year-round symptoms who have the option to use ICS only during allergy season. And there are also situations in which treatment with an ICS-containing medication could be unfavorable, such as due to side effects, allergies, or concerns with the limited evidence for as-needed ICS use in some populations. Refer to Section 5 of the full report for details. We performed a cross-sectional descriptive analysis of SABA utilization among Utah Medicaid fee-for-service patients with asthma, focused on identifying the proportion of patients with frequent SABA use within the one-year period of October 1st, 2022 to September 30th, 2023. This table shows the eligibility criteria for our selected cohort. The criteria are listed in the order they were applied. First, we identified patients who filled a prescription for at least one inhaled SABA product during the study period, and the date of the first SABA fill was considered the index date. Next, we required that patients had an ICD-10 diagnosis code for asthma other than exercise-induced bronchospasm within the 12 months before the index date. To reduce confounding, we excluded patients with ICD-10 codes for conflicting chronic pulmonary diagnoses such as COPD or cystic fibrosis, anytime from 12 months before the index date to the end of observation. To be included, patients were also required to have at least 2 months of Medicaid eligibility between the index date month and the end of the study period to ensure that they had sufficient time to fill at least 3 SABA inhaler prescriptions. We measured SABA and maintenance therapy utilization based on outpatient pharmacy medication fills during the observation interval, which was the duration from the first SABA fill or the index date to the end of the study period or the last month of the patient's Medicaid eligibility. SABA utilization was assessed as the sum of SABA-only or albuterol budesonide inhaler or nebulizer products filled during the observation interval, normalized to the number of 21 or 200 actuation inhaler canister equivalents, which I call SABA canister equivalents, abbreviated SCEs. We considered frequent SABA use to be total SABA utilization of 3 or more SCEs. Prescription fills for any ICS-containing and/or LTRI therapy counted as maintenance therapy utilization. We calculated the intensity of maintenance therapy using the proportion of days covered, or PDC, during the observation interval. PDC is calculated using the days supply for any eligible maintenance therapy filled to determine the proportion of days in the interval that the patient would have had the medication available for use. We carried forward days supply for medications of the same type as either ICS-containing therapies or LTRA. If the days supply for both an ICS-containing and LTRA therapy overlapped during the observation interval, the overlapping days with both types counted as a covered day only once. Notably, while we refer to ICS-containing medication as maintenance therapy for simplicity, it is possible that some patients who filled an ICS-containing therapy were using it as needed as part of a guideline recommended reliever regimen. Okay, so next I will provide an overview of our SABA utilization results, first for the entire selected cohort and then by subgroup. Overall, 1,400 patients met our eligibility criteria and had a median Medicaid coverage duration of 9 months during the study period. 38% of patients met the criteria for frequent SABA use, filling 3 or more SABA canister equivalents, abbreviated SCEs, during the observation interval. 4.2% of patients filled 12 or more SCEs. The mean SCEs filled during the 1-year observation was 3.3, and the mean SCEs filled per month was 0.42, which corresponds to filling approximately 1 SABA canister equivalent every 2.4 months. We provided descriptive statistics to account for the variation in observation length among the cohort. In other words, the variable time patients had Medicaid coverage. The quantity of SCEs filled appeared correlated with observation length. Only 10.1% of patients with the shortest observation interval of 2 to 3 months filled 3 or more SCEs, in contrast with 65.7% of the 289 patients with 12 months of observation. However, if you consider the last column, which is the mean SCEs filled per month, the mean is numerically greatest among patients with the shortest observation length at 0.63, corresponding to filling approximately 1 SABA canister equivalent every 1.5 months. We looked at age subgroups according to the groupings used in GINA treatment recommendations. Most patients in the cohort were 12 years or older, with 21.4% of patients being 11 years or younger. Generally, the frequency of SABAs filled increased with age. 27% of patients under 6 years filled 3 or more SCEs, compared with 39.5% of those aged 12 years or older. The mean for the total SABAs filled and SCEs filled per observed month were also numerically greatest in the oldest age group. 68.9% of patients in the total selected cohort did not fill any ICS-containing or LTRA therapy during the observation interval. About 30% of patients filled at least one prescription for a maintenance therapy. The left side of this diagram shows the breakdown of maintenance therapy types filled. 27.1% of patients filled an ICS-containing medication, and 8.9% of patients filled a prescription for an LTRA, including 5% of patients that filled a prescription for both types. Among the 553 patients in the total cohort with frequent SABA use, 60% did not fill any ICS or LTRA therapy. Our final subgroup analysis was the frequency of SABAs filled by maintenance therapy intensity, reflected by the PDC categories of 0% indicating no maintenance therapy fill, up to the highest category of at least 75% of observation days covered by maintenance therapy. The mean of total SCEs filled during observation and mean SCEs filled per observed month were numerically highest in the subgroup of patients in the 75% or higher PDC subgroup. The mean SCE per month of 0.66 in this subgroup corresponds to filling approximately 1 SABA canister equivalent every 1.5 months. Observational studies, recent US and international guidelines, and expert guidance generally agree that filling prescriptions for 3 or more SABA canisters per year is associated with worse asthma outcomes, and that the magnitude of associated risk increases with greater SABA usage. GINA defines frequent SABA use as filling 3 or more 200 actuation SABA canisters per year, roughly corresponding to daily or more use, as the threshold for an increased risk of exacerbations regardless of asthma severity or concomitant ICS treatment. Reviewed asthma guidelines recommend monitoring patients' recent SABA use as one indicator of poor asthma control, but guidelines do not imply that access to reliever therapy should be halted after a particular threshold of use. Our cross-sectional descriptive analysis found that 38% of Utah fee-for-service patients in our cohort filled 3 or more SCEs within 12 months, which is comparable to the percentage of patients with frequent SABA use reported by the Missouri Medicaid program and by a recent observational study that included US patients. 69% of the total cohort of 1,400 patients and 68.7% of patients 6 years or older did not fill a maintenance therapy in the observation period. It could be that many of these patients are in step 1 of therapy. Even so, those aged 6 years and older may be considered for ICS therapy either on an as-needed basis whenever SABA is taken or on a continuous basis according to GINA recommendations. However, there may be some potential barriers to implementing GINA recommendations with respect to payer restrictions on ICS products and the lack of FDA approval for as-needed use. Among the subset of patients with frequent SABA use of 3 or more canister equivalents in the 1-year period, 60% did not fill any maintenance therapy. This could be a high priority group for consideration of adding an ICS. Nonetheless, consider the SCE utilization we calculated may not reflect true usage, so not all of these patients may be appropriate for maintenance therapy. Additionally, there may be patient-specific factors that could make adding an ICS or LTRA unfavorable, as outlined in page 21 of the full report. We observed that patients with a higher intensity of maintenance therapy tended to have greater SABA usage, which goes along with the idea that more frequent SABA utilization could be a marker of higher disease severity in addition to uncontrolled disease. Limitations to our claims-based descriptive analysis should be considered. A considerable limitation is that prescription claims may not reflect the true usage of the medication by the patient. This is especially true for rescue therapies where on-hand supply is needed at multiple locations. For example, a child with asthma may initially fill multiple inhalers at once to have one at home, one to keep in their backpack for school, and or another to have in another caretaker's location. Such a patient could be flagged at the very initial fill or even first refill as a frequent utilizer, which may be an over-assumption. There could also be other reasons that the number of fills may not reflect true or complete usage. Also note that Utah Medicaid program implemented quantity limits of 2 SABA inhalers per 30 days sometime in the past year, so SABA utilization during our study period may not reflect SABA use with these new limits in place. We randomly selected 5 other state Medicaid programs to survey their SABA-related policies, including California, Oregon, Washington, Missouri, and New York. Each of these programs prefer at least one SABA product on their drug list, and to the best of our knowledge, none have SABA-specific prior authorization criteria. Of these 5 programs, only Missouri has implemented quantity limits for SABAs. Missouri limits adults without cystic fibrosis to 3 SABA-only inhaler canisters every 6 months and limits patients of all ages without cystic fibrosis to 120 SABA-only nebulizer vials every 2 months. We are also aware that Oregon Medicaid considered SABA quantity limits of 6 SABA inhalers every 6 months at their October 2023 meeting, but this proposal was not approved and they elected to implement educational and retrospective drug utilization review interventions instead. Utah Medicaid may consider implementing policies or programs to monitor or educate about the use of SABAs for asthma. The following are some options that the DUR board may consider recommending or discussing. First, you may consider implementing retrospective drug utilization reviews to notify providers of Utah fee-for-service patients with asthma who filled a threshold of SCEs within some time frame, which should be at least 3 SCEs within at least 2 and up to 12 months. Although we counted nebulized and inhaler products in our analysis, for feasibility, SABA utilization could track only the number of SABA inhaler canisters filled. Another retrospective drug utilization review to consider is notifying providers of patients that might be a candidate for starting maintenance therapy or reliever therapy, including ICS. This program could prioritize messaging providers of patients who filled 3 or more SABA canister equivalents. It's important to highlight that if Utah Medicaid implements a program to encourage prescribers to incorporate ICS into reliever therapy as ICS SABA or ICS formoterol, which are guideline supported but off-label uses, measures should be taken to guarantee patient access. Currently, preferred ICS-only inhalers and budesonide formoterol are limited to filling 1 inhaler every 30 days, which is potentially a barrier to as-needed use, especially for patients that use these therapies as part of their maintenance and reliever regimens, since that limit would primarily accommodate maintenance use. Another program that Utah Medicaid could consider implementing is performing educational outreach to providers and/or patients about the risks associated with SABA over-reliance in order to promote other best practices in asthma care. The Utah Department of Health and Human Services has a Utah asthma program. Perhaps Utah Medicaid could consider collaborating with this program for parts or all aspects of educational initiatives. Finally, if SABA quantity limits are desired, we suggest implementing limits very cautiously to allow flexibility for practical needs of patients and with accommodations or exclusions for certain populations like people with cystic fibrosis, COPD, and/or EIB. Caution is advised regarding limiting patient access because SABAs are a potentially life-saving medication for acute bronchoconstriction. Also consider that patients may not be able to secure a prompt appointment with their providers when they are denied a refill by the payer at the pharmacy, and that patients may require on-hand supply at multiple locations. When guidelines and expert guidance recognize frequent SABA use as a marker for uncontrolled asthma, they do not advise or imply restricting patient access to SABAs after a certain amount. Rather, guidelines imply that patients with frequent SABA use may be candidates for asthma regimen optimization, for example, adding maintenance therapy and/or a different reliever. Thus, the priority could be placed on interventions like those I previously mentioned that focus on optimizing the patient's asthma medication regimen. All right, well, thank you for your time and attention, and please let me know if you have any questions.
Thank you, Lauren. We appreciate the presentation. It was well done, and I think gave us a good view and overview of where the Utah Medicaid population is with regards to SABA utilization. So I would open it up to anyone on the board if you have questions for Lauren around any of the data or any of the discussion points that she went through this morning. Let's see, Dr. Britton.
Yes, thank you so much, Lauren. That was a wonderful presentation. I always learn so much with these. Do you feel, just from the data, do you feel that there is a need either economically or clinically for us to do any limitations, or should we, or would you recommend more focusing on education?
By limitations, do you mean quantity limits for SABA products?
Right.
Like I said, one consideration is I don't know if our study captured the current quantity limits that Medicaid has in place of 2 inhalers per 30 days. So I'm not sure if it would make sense to make changes since that it might be a recent change, and maybe the Medicaid program could elaborate on when that went into place. But overall, I feel that guidelines and expert guidance don't suggest restricting access to SABA inhalers. They suggest optimizing the patient's regimen, adding ICS to their reliever regimen, or adding ICS as a maintenance therapy. So I think that retrospective DUR to talk to providers to encourage optimizing those therapies in people who are frequent SABA utilizers would be a good approach, in my opinion.
That sounds wonderful. Thank you so much.
I can give a little background on the quantity limits that are currently in place. The quantity limits that are currently in place are the same as what they were pre-COVID. And during COVID, we removed those quantity limit restrictions as you know, it is a respiratory infection, and we didn't want to limit access during the public health emergency. And we re-implemented the old limits with the end of the public health emergency. And so that's where we are. A caveat to that is that with the Change Healthcare outage, we're being a lot more liberal with implementing limits because we don't have the ability to process prior authorizations and implement some of the controls that we typically have. And so, as I understand it, those limits are temporarily on hold while we're awaiting the full restoration of the Change Healthcare systems. And from the perspective of the state, we're more interested in focusing on education and outreach, and helping providers and patients optimize their treatment. Focusing on those patients who do have high utilization of SABAs or SCEs, and recommending ICS and maintenance therapy where those therapies are underutilized.
Thanks, Brian. Lauren, I guess I know, having looked at an awful lot of pharmacy data over the years, a lot of times you look at it and you have a feeling there's something here that needs to be fixed, and sometimes there's a feeling that no, everything's okay. We might have a few outliers. Which is yours?
So you're asking, do I
It-
think
it-
there were
Do you feel as if if things are moving forward in a, and I'm not going to call it an appropriate way or I mean, but it's a semi-appropriate way, as clinically appropriate as possible under the current structure, or there's something broken we need to fix?
Well, I think, this was
Put me on the spot, I know.
well, so we had a median of 9 months of follow-up on patients, and there were 500 or 60% of those who did frequently utilize SABAs, having 3 or more canister equivalents filled, didn't fill a maintenance therapy in that time. That seems like a relatively high percentage to me, and could suggest that there are at least some of those patients who could benefit from adding that either as part of their reliever regimen or maintenance regimen. As I said, there's definitely limitations to the data, and it could be that a lot of the population has very mild asthma, and that's why they're only filling SABAs. But observational studies that suggest, even patients with mild asthma, if they are truly frequently using that many, using that much of the SABAs, they are at risk for exacerbations. And so regardless, I think that there could be an opportunity to converse with their provider, converse with the patient to try and optimize things or see what's going on.
So, and I guess my belief would be simply adjusting the quantity limit is not the way to solve the problem. The patients are receiving some treatment today, which is better than no treatment, and their treatment could be enhanced with the addition of an ICS. All we'll do is leave people standing at the pharmacy not being able to get their inhaler. It is my view, I think, on that. So, other thoughts, comments from the committee? Is there a recommendation from the committee? Dr. Brett?
Sorry, I'm moving around here. So I would, I don't know if it is a motion or not, but I would love to frame a motion to particularly target those patients that seem like they're not getting the adequate therapy that they need. To target them either through patient and provider education or whatever form we do. Does that need a motion, or is that more just a discussion saying, yes, go for it, health department, let's do this education outreach to these patients who are particularly showing signs that they're maybe not adequately managed with their asthma?
Yeah, I don't know that they need a motion per se, but I think, you kind of put one forward and I'll second it. And that way we kind of formalized our comment of saying, we're comfortable with the current quantity limits, and, identifying those potential patients at risk, and, trying to educate providers and patients going forward. Is that something that, Brian, nothing is easy, but is it doable for the department?
I believe so. Again, that's the direction that we are interested. I think we're on the same page as what you outlined, not so much focusing on additional limitations, but focusing on, outreach, education, and patient-specific DUR interventions. Patient and provider, I guess.
And well, we will take everyone else's silence as silent agreement and, you know, give that recommendation as a board back to the state to move forward with education. All right. I think Stephanie, you're next on the agenda. And I don't have it up, so I am at a blank on the name of the drug.
All right, thanks, Eric. Let me know if you can't see this. So this is a prior authorization that we were unable to get to last UR meeting, so it's indicated for sickle cell anemia, just as a refresher. So it's for Oxbryta, generic name is voxelotor. For our criteria, they are the patient is age 4 years or older, the patient has a diagnosis of sickle cell disease, the medication is being prescribed by or in consultation with a specialist in the treatment of sickle cell disease. The patient has symptomatic or severe anemia despite at least 4 months of therapy with a maximally tolerated dose of hydroxyurea. That is per clinical guideline recommendations to start with hydroxyurea, which is the standard of care in sickle cell disease. The patient has a hemoglobin level of 10.5 grams per deciliter or less, indicating anemia, and the patient has not received red blood cell transfusions within the last 30 days. For reauthorization, we asked that the provider show that the patient has had an increase in hemoglobin from baseline hemoglobin level since starting the medication, showing an improvement. And as with other medications, we have an initial authorization for 6 months and reauth up to 1 year. Any questions?
Let's see.
Okay, I see
Monet had a comment.
Monet's question. Yes, it's the maximally tolerated dose. So if they don't tolerate hydroxyurea, then we don't require that 4-month trial.
All right. Other thoughts from the committee? This feels as though it's very specific to the label that was approved for the product. Is that correct?
Yes, it is.
Okay. Comments from the committee? Hearing no comments, do I have a motion of some sort?
This is
I
Sam.
move to
Motion to
approve.
approve.
Sorry.
Second it.
Okay, we have a motion to approve in a second. All in favor? Yay.
Aye.
Any opposed? Like clockwork, that motion passed, and so prior authorization is approved, although based on the earlier update, you're not able to do prior authorizations right now. Is that
Right.
correct?
Yes.
So at the point in time you can, that is approved. In our next meeting coming up, we have a discussion around montelukast, I believe. Trying to find my agenda again, guys, sorry. And our next meeting is May 16th. Any final thoughts, parting comments? All right, looks to be another beautiful day in the neighborhood today with lots of sun. So everybody get out and enjoy a little bit of sunshine. And I would ask if there is a motion to dismiss. I will make a move to dismiss.
I'll second it, Eric.
All right. All in favor?
Aye.
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 All right, guys. We will see everybody next month on the 16th.
Thanks, everybody.
Thanks.
Thank you.
Have a good day.
Thank you.